Hi everyone, my name is Dawn and I'm a physiotherapist from Singapore General Hospital. This short lecture is on understanding Parkinson's and I would like to acknowledge Ms. Shamini Balakrishnan for her contributions in creating the original slides for the previous presentation. We hope that by the end of this lecture, learners should be able to list the motor and non-motor presentations of Parkinson's, to classify patients according to the Hone and Yahr stages, discuss the medical management of Parkinson's and their side effects, and also discuss the goals of physiotherapy management according to the Hone and Yahr stages. Parkinson's is a progressive neurological condition which largely affects older adults. The underlying physiology involves a lack of dopamine, which results from a degeneration of dopaminergic cells in the basal ganglia. The basal ganglia comprise of the substantia nigra, the caudate and putamen, the globus pallidus, as well as the subthalamic nucleus. At times, we may see patient referrals indicating idiopathic Parkinson's disease, Parkinsonism, or atypical Parkinsonism. So what do all these mean? Parkinsonism refers to a collection of signs and symptoms which include tremor, rigidity, bradykinesia or reduction in speed of movement, as well as postural instability. People with idiopathic Parkinson's will show at least two or more features of Parkinsonism, which start out as asymmetrical in the early stage of Parkinson's. So this means that people with idiopathic Parkinson's will may show tremors on one side of the body in the early stage of the condition, or they may also show reduced arm swing and step length on one side of the body. As the condition progresses, these people will start to show symptoms on both sides. Additionally, people with idiopathic Parkinson's will show good response to levodopa medications. There will be a period of what we call the honeymoon period in the early stage of condition when the levodopa medications may remove nearly all the features of the Parkinsonism. However, people with Parkinson's plus syndrome or PPS or atypical Parkinsonism may also show features of Parkinsonism. However, they will not respond as well to the levodopa medications. We will talk more about people with Parkinson's plus syndrome or atypical Parkinsonism towards the end of this lecture. The four cardinal signs of Parkinson's include tremor, rigidity, akinesia or bradykinesia, and finally postural instability. Let's begin first with tremors. So the tremors noted in Parkinson's is often pill rolling tremor. It looks as though the patient is rolling a pill between his thumb and index finger of a frequency of 4 to 6 Hz. And it's usually the first symptoms reported beginning on one side of the body before progressing to both sides towards the later stages of the condition. So resting tremors occurs at rest and may improve with movement, and it usually disappears during sleep. Action tremor can be observed when the patient moves. The amplitude of the tremor increases as the disease progresses, and also we may also notice more tremor when the patient becomes more anxious. Rigidity or stiffness is due to hyperreflexia and hypertonicity in antagonist and agonist muscle groups. Rigidity is detected by slow, passive movements, unlike spasticity, which is detected by a quick stretch. There are two main types of rigidity, that's cogwheel and lead pipe rigidity. In cogwheel rigidity, there is tremor superimposed on rigidity. However, in lead pipe rigidity, the resistance is slow and sustained. The next cardinal sign of Parkinson's include akinesia or bradykinesia. Akinesia refers to a loss of movement, such as lack of facial expression or eye blinks. Akinesia can also be seen in walking tasks, such as difficulty in initiating the first step during walking, as well as coming to a sudden stop in walking known as a freezing episode. On the other hand, bradykinesia refers to slowness of movement, such as reduced walking speed. There is also another common term called hypokinesia. Hypokinesia refers to a reduction in amplitude of movement, such as reduced step length or arm swing, or reduced handwriting size, known as micrographia. The fourth or final cardinal sign of Parkinson's is postural instability. Postural responses during externally induced perturbations are reduced. For example, in the pool test, the ankle, hip, and stepping strategies are diminished or absent. Patients may respond by taking several steps backwards to recover their balance, or they may fall into the therapist's arms. So this puts the patients with Parkinson's at high risk of falls. Other motor symptoms of Parkinson's include a stoop posture with a very flexed thoracic spine and also flexed knees, softness of voice, loss of facial expression as we've mentioned, poverty of movement such as decreased arm swing, and this is known as hypokinesia, as well as micrographia, which is small, cramped handwriting as can be seen in the picture here. So as the handwriting becomes smaller and less legible, sometimes checks can be bounced back as well. This kinesia is a common movement disorder seen in people with advanced Parkinson's. It's actually the side effect of after many years of levodopa medications where blood plasma levels of dopamine fluctuate. As can be seen from the video here, this kinesia is actually an involuntary, purposeless writhing movements with dystonic posturing of hands, feet, trunk, and neck. Besides motor symptoms, people with Parkinson's also experience non-motor symptoms which can be very disabling as well. Examples of non-motor symptoms which can occur early in Parkinson's, possibly before the motor symptoms appear, include olfactory deficit, where patients with Parkinson's may complain of the loss of sense of smell. Also constipation, rapid eye movement, or REM sleep behavior disorder, and that is where patients may act out their dreams. For example, they may shout, they may move their legs and arms. There may also be mood disorders such as depression or anxiety, and these early symptoms will continue throughout the course of the Parkinson's as well. Other non-motor symptoms include sleep disturbances such as insomnia. EDS refers to excessive daytime sleepiness. There's maybe also bladder problems such as frequent or urge incontinence as well, nocturnal urination, going to the toilet at night, sexual problems, fatigue, slow thinking, and aches and pains. Let's take a look at the motor and non-motor symptoms in the timeline of Parkinson's. So in the pre-motor years, before the motor symptoms appear, and that might be 4 to 6 years before the motor symptoms appear, people with Parkinson's may experience REM sleep behavior disorders, constipation, depression, and also loss of sense of smell. And at diagnosis, people with Parkinson's often present with unilateral symptoms of tremors, rigidity, or akinesia or bradykinesia. And followed as the disease progresses, symptoms will appear on both sides. And subsequently, there might be motor complications or dyskinesia after years of taking levodopa medications, where the blood plasma levels of dopamine fluctuate. And as the disease progresses, we will see the appearance of postural instability or falls. And finally, when the disease have progressed to the cerebral areas, we might see psychosis or dementia. The Ho and Ya stage is often used to classify patients with Parkinson's into how advanced they are in terms of their condition. So the Ho and Ya stage comprises of 5 stages, stage 1 being the very early stage, or stage 5 being the most advanced condition. So let's look at each stage in detail. For stage 1, the condition is not disabling. Patients experience mild unilateral symptoms. For example, they may show tremor on one side of the body. They may show mild slight changes in their posture. They may appear a bit stooped. They may show changes in their walking as well as facial expression. In stage 2, patients will often experience bilateral disease. They may show symptoms on both sides, such as tremor on both sides. However, they are without impairment of balance. They may have a slight kyphotic posture. They may show slowness in their movement as well as speech problems. However, their postural reflexes are still intact. For patients in stage 3, there's significant slowing of body movements, moderate to severe symptoms, and there is the presence of postural instability. And this can be seen during the retropulsion or pull test, where there is no recovery. The therapist will have to catch the patient. Walking is impaired, but patient is still able to walk independently without help, and they are still physically independent in their ADLs. In stage 4, the patients show severe symptoms, rigidity and bradykinesia. They are partly disabled. Walking is more impaired, but it's still possible without help. In stage 5, patients has experienced a higher level of disability. The walking and standing is now impossible without help, and they require continuous nursing care. There is also the modified Ho and Ya stage with the addition of stage 1.5 and stage 2.5. In stage 1.5 of the modified Ho and Ya stage, there is unilateral disease plus axial involvement. Axial involvement meaning a midline involvement, such as loss of facial expression, loss of trunk rotation. And in 2.5, there is bilateral disease, but there's recovery on pull test. So this is a nice table because it shows the stage as well as the corresponding phase of disease, whether it's early, mid, or late, as well as the number of years of having Parkinson's. Okay, so we can see to differentiate between stage 2 and stage 3, you would have to do a pull test, and if the therapist has to catch the patient during the pull test, so the patient will be staged in stage 3 onwards. This video shows the pull test, and we can see the loss of postural response when the patient is perturbed backwards. Let's take a look at this short case study. David was diagnosed with Parkinson's and was referred to physiotherapy. During the pull test, David lost his balance and required assistance from the therapist to stabilize him. He required assistance from his wife for dressing and showering, but was able to walk by himself. which Hohenya stage will you classify, David? Pause the video, refer to the previous 2 slides, and have a think about the answer. Because David requires assistance from the therapist to stabilize himself during the pool test, so his Hohenya stage would be from stage 3 onwards, 3, 4, or 5. However, because David requires assistance from his wife for his activities of daily living, but is still able to walk independently by himself, so his stage would be a Hohenya stage 4. When motor symptoms start to affect patients' activities, neurologists will usually start to prescribe Parkinson's medications. And because dopamine does not cross through the blood-brain barrier, it's given in the form of levodopa, which then can pass through the blood-brain barrier and be converted into dopamine. However, because there may be competition in the small intestines for active absorption, usually levodopa medications are not taken with the meals itself, because there might be competition with the protein in the diet, so that there will be less absorption of the levodopa, and therefore less levodopa may reach the brain as well, resulting in less dopamine release. So therefore, patients are often advised not to take their levodopa medications with meals. They are usually taken apart from meals. There are also other types of Parkinson's medications. For example, COM inhibitors help to preserve the amount of levodopa in the brain, and there's also dopamine agonists, which help to mimic dopamine, and then there's also the MALT-B inhibitors, which help to preserve the existing dopamine in the system. Common levodopa medications include your Medopa as well as Sinemet. Medopa is made up of levodopa and benzerazide. So benzerazide helps to prevent the breakdown of levodopa. Sinemet comprises of levodopa and carbidopa, and carbidopa helps to prolong the life of the levodopa as well. So there are potential side effects of Parkinson's medications or your levodopa medications, and these include symptoms such as low blood pressure, postural hypertension, nausea, confusion, as well as dyskinesia. And dyskinesia happens when there's prolonged use of levodopa medications. So if you notice that your patient has low blood pressure or postural hypertension as well, you may write back to the neurologist so that their medications can be titrated. This slide shows other medications apart from your levodopa medications. And over here on the right, amantadine and also your anticholinergics may be used also for tremors as well. As Parkinson's progresses, patients may experience motor fluctuations where they may experience on and off periods over the day. On periods refer to the times when the symptoms, the Parkinson's symptoms are very well controlled. Patients feel that they are moving very well, and they may experience on periods about they may start to turn on about half an hour after their Parkinson's medication. Off periods refer to the times of the day when the Parkinson's symptoms come back and they start to move more slowly, or their tremors might worsen, and so they may commonly say that their off periods may come about half an hour before their next dose of medication. So in this graph on the right, we see the yellow shaded area represent dyskinesia, okay, and the pink color shaded area show the off state of the patient. and the blue color area refers to on state without dyskinesia. So after many years of taking levodopa medications, and as the disease progressed, we could see that the off state of the patient will start to increase, and also the dyskinesia also will start to increase as well, due to dysregulation of dopamine, blood plasma dopamine levels due to the prolonged use of levodopa over many years. So as the disease progresses and after many years of taking levodopa medications, we see that the on state of the patient would actually start to reduce. This video shows the walking pattern of a person with Parkinson's during the on and the off phase. During the off phase, we see a typical Parkinson's walking pattern with very narrow base of support as well as reduced arm swing, and there's gait freezing during straight path walking. We also see freezing of gait during turning. We also noticed a stoop posture of the patient with bent knees. So the patient takes very small steps, shuffling steps in his gait. There is also freezing of gait while walking through doorway. And we also notice freezing of gait during rapid turning on the spot. Even during the off phase, using visual cues will improves the patient walking pattern with increased step length observed, as well as using auditory cue where the patient pace each step with the metronome beat, and this minimizes freezing of gait. During the on phase, we see a marked improvement in the patient's walking pattern with increased step length, improved walking speed, as well as increased bilateral arm swing. Walking through the doorway improves, and so is the performance during rapid 360 degrees turn. When Parkinson's medications start to lose their effectiveness, for example, off periods increase in duration, dyskinesia periods increase, and on periods reduce, deep brain stimulation may be offered. So here leads are inserted into the brain, and where electrical impulses are delivered, so to stimulate the release of dopamine. Okay, so the window of opportunity opens at least 4 years of disease duration, or when there's not adequate control, is when the symptoms are not adequately controlled by medication, including motor complications for at least 4 months, and when patients with displaying one of or more of the following symptoms: on-time disabling dyskinesia, off-time disabling tremor, rigidity, akinesia or bradykinesia, unpredictable motor fluctuations, and when there's medication-resistant tremor. So the window of opportunity closes when the symptoms no longer respond to dopaminergic medication, when the patient is severely disabled even in the best on stage, when there's other medical conditions which prevent surgery, and when there is the presence of dementia. Let's now take a look at Parkinson's plus or atypical Parkinsonism syndromes. Here's a diagnostic approach to atypical Parkinsonism syndromes. So we have the secondary Parkinsonism, the hereditary Parkinsonism, as well as the atypical Parkinsonisms. So let's start with the secondary Parkinsonism, where there is usually a primary cause. For example, in people with vascular PD, the Parkinsonism may be seen, signs of Parkinsonism may appear after a stroke. And then there's also the drug induced Parkinsonism, where the Parkinsonism's symptoms may disappear after the medication is stopped. And then there's the normal pressure hydrocephalus, where the Parkinsonism may disappear, so may reduce, Parkinsonism symptoms may reduce after a VP shunt is inserted. Then we have the hereditary Parkinsonism, such as these that has the genetic causes, such as spinocerebellar ataxia, as well as Wilson disease. And then we have the atypical Parkinsonism, which include your progressive supranuclear palsy, cortical basal degeneration, multiple system atrophy, as well as dementia with Lewy bodies. How do we differentiate atypical PD from idiopathic PD? So here are the features predictive of atypical Parkinsonism. For example, rapid disease progression. So patients may deteriorate rapidly over the first 2 years. So this is not typical of idiopathic Parkinson's. There's also early gait instability and falls. People with Parkinson's typically may start to experience postural instability and falls after 5 to 10 years of the disease, whereas patients with atypical PD may start to fall early in the course of diagnosis, for example, in 1 to 2 years. So that's not typical. So, for example, there may be absence of tremor, there may be irregular, jerky tremor or myoclonus, and there's poor or no response to levodopa. So people with atypical PD may also show additional features of atypical PD. For example, abnormal eye movements. For example, in people with progressive nuclear palsy, they may lose their vertical eye movements, or they may show cerebellar signs, for example, in people with multiple system atrophy. There might be dysautonomia as well in people with multiple systems atrophy. There may be severe dysarthria, slurring of speech. There may be apraxia or alien limb syndrome in people with cortical basal syndrome. And there may be early dementia in people with dementia with Lewy body. This is a nice summary of the characteristic features of idiopathic Parkinson's and other forms of Parkinsonism as well. Yeah, so for example, people with Parkinson's disease, we would typically see a narrow base gait pattern, asymmetrical presentation as well. One side is more affected than the other, stoop posture, and also early freezing and falls are rare. Okay. However, in other sort of Parkinsonisms, for example, progressive supranuclear palsy, the gait of pattern of the patient is a very wide base gait. Freezing and falls are common in the early are common early in progressive supranuclear palsy. Likewise, for cortical basal degeneration, there might be unilateral presentation, unilateral leg apraxia, there might be myoclonus, and then there's also white base freezing and shuffling as well. And these usually does not respond as well to levodopa medications, and as well as there's early disability will set in. For example, patients may start to fall early, and also there's also freezing early on as well. People with vascular Parkinsonism, they move their hands well. There's a kind of lower body Parkinsonism. They may have shuffling gait, but their hands will move very well. And these people may also have a white base gait as well. Let's take a look at this video of walking patterns of people with progressive supranuclear palsy. Consider what are the differences from the videos of people with idiopathic Parkinson's.
Of unsteadiness and difficulty in walking is a common presenting feature of PSP. The gait is broad-based, ataxic, and is often unkindly described as the gait of a drunken sailor or a dancing bear. There is often preserved arm swing in contrast to Parkinson's disease, and the gait is frequently reckless in that patients seem to be unaware of the dangers that they are running by getting up quickly from a seated position and moving faster than their brain seems to be able to dictate. This leads to damaging and dangerous falls, particularly backwards. Another complaint is of blurring of vision and occasionally double vision, which can be one of the earliest presenting features of PSP. This is due to a disturbance of eye movements and difficulties in keeping the eyelids open to voluntary control. Some patients will have involuntary eye closure, particularly when talking or watching television, which is called blepharospasm or apraxia of eyelid opening, and others will have difficulties negotiating stairs because of a difficulty in looking down. Eye movements form a particularly important part of the neurological examination in PSP. And the classical findings are of slowness of vertical eye movements, together with limitation of eye movements.
Here's a table summarizing the differences in the walking pattern and eye movement of people with progressive supranuclear palsy, PSP, or idiopathic Parkinson's. In terms of gait, people with PSP shows some form of recklessness. Their gait pattern is wide base, unlike the gait pattern of a person with idiopathic Parkinson's, which is narrow based. And also the arm swing is preserved bilaterally in people with PSP. For people with Parkinson's, we see an asymmetrical loss of arm swing in the early stage, followed by bilateral loss of arm swing. For PSP, there's marked postural instability. Even in the early stages, patients start to fall early. They have difficulty getting out of the chair. They keep falling backwards. However, for people with idiopathic Parkinson's, postural instability only sets in the more advanced stage of the condition. In terms of eye movements, people with PSP lost the ability to track vertically upwards and downwards. However, they are still able to track horizontally. So, however, for people with idiopathic Parkinson's, the vertical eye movements are preserved. Let's now take a look at clinical practice guidelines for the physiotherapy management of people with Parkinson's. According to the European Physiotherapy Guideline for Parkinson's, people with Parkinson's should be referred for physiotherapy across the various disease stages. In the early stage of the condition, referrals should start soon after diagnosis for self-management advice, education, and coaching about remaining physically active. In the mid-stage of the condition, the focus should be on motor impairments affecting physical capacity and function. This includes training in walking, balance, transfers, or pain management. In the late stage of the condition, the person with Parkinson's may be at home, in a hospital or care facilities. Physiotherapy can still help to preserve physical capacity and function and to reduce the risk of falls. As the condition progresses, management by a multidisciplinary team is required. The guidelines also recommend Parkinson-specific physiotherapy. Exercise can be used to minimize deterioration in strength, endurance, flexibility, and balance. As the condition progresses, movement strategies can also be taught to overcome difficulty in generating automatic movement. Some of these strategies include using external cues such as auditory, tactile, or visual, internal cues such as mental rehearsal and visualization. Also, strategies for dual tasking and improving attention span are recommended. The recent Parkinson's exercise recommendations proposed that people with Parkinson's participate in 150 minutes of moderate to vigorous exercise per week. And the types of exercise include aerobic activity, which is 3 days per week for at least 30 minutes per session of continuous or intermittent at moderate to vigorous intensity. And also strength training of 2 to 3 non-consecutive days for at least 30 minutes per session of 10 to 15 reps for major muscle groups, resistance, speed, or power focus. In terms of balance, agility, and multitasking, it's recommended 2 to 3 days per week with daily integration if possible. And these exercises include multi-directional stepping, weight shifting, dynamic balance activities, large movements, multitasking, such as yoga, tai chi, dance, boxing. And finally, stretching is also recommended of more than 2 to 3 days per week, with daily being most effective. And these include sustained stretching with deep breathing or dynamic stretching before exercise. This slide contains the links to the different components of exercises which are important for people with Parkinson's. It's produced by Parkinson Society Singapore, and you can click on the links to view the videos. There are many benefits to exercise, and these include increased cardiovascular fitness, improving coordination and balance, increasing muscle strength and flexibility, preventing joint deformity, improving joint mobility and posture and movement control, and resulting in patients having greater confidence in their movement and mobility. When should a person with Parkinson's exercise? Would it be during the on or the off period? The recommendation would be to exercise during the on period so that a higher intensity of exercise can be achieved, because the movement of the patient would be much better than during the off period. However, physiotherapists should teach patients movement strategies that can be utilized during the off period so that the patients can move better. To summarize, we have talked about the complex motor and non-motor problems which people with Parkinson's experienced. We have also talked about the Ho and Ya stage and how it is used to classify patients into the different stages of the condition. We have also discussed about how patients with Parkinson's, idiopathic Parkinson's are different from those with atypical Parkinson's. So people with atypical Parkinson's progress faster in the condition. Falls and postural instability appear soon after diagnosis, and also they show response to treatment, to levodopa treatment. We have also talked about the different types of medications for people with Parkinson's and their potential side effects, which physios have to take note and also report back to the neurologist for a review. So physiotherapy is recommended across the various disease stages, and also Parkinson-specific physiotherapy is recommended for people with Parkinson's, and this includes the use of cueing and movement strategies. And finally, because of the complex motor and non-motor impairments and disability, a multidisciplinary team approach is recommended. Thank you very much for listening.